Hello, my name is David Poetker, and on behalf of my co-author, Dr. Jessica Southwood, we'd like to thank the editors for allowing us to present our book chapter entitled Endoscopic Sinus Surgery, Evidence and Outcomes. We have nothing to disclose. This is our outline for the chapter. Give an introduction, talk specifically about health utility, and then we'll do a deep dive into the evidence for endoscopic sinus surgery, including the long-term data, the extent of surgery, frontal sinus surgery, and then the timing of endoscopic sinus surgery. And we'll wrap up with conclusions and some key points. So as an introduction, why study outcomes? Well, insurers want to invest in procedures with high rates of return that leads to decreased costs. Patients want to know what to expect from endoscopic sinus surgery, CT scan correlates poorly with patient symptoms, and nasal endoscopy has poor intra-rater reliability. How do we know all this? Well, Zach Soler did a study looking at 242 patients with chronic rhinosinusitis who chose either endoscopic sinus surgery or medical management. He found no difference in demographics, in household income, the medical insurance, whether it be private or public, social support, the patient's risk aversion, their trust in the physician, or the disease severity as measured by CT scan. Only SNOT-22 was significantly worse in patients electing endoscopic sinus surgery. In fact, SNOT-22 scores accurately discriminate between patients electing endoscopic sinus surgery versus medical management 72% of the time. This suggests it's a great metric for disease severity. The most common criticism and biggest limitation of health-related quality of life instruments are the lack of control groups. Control groups minimize the changes of placebo or the natural progression of the disease process from impacting the results of the study. Although it would be ideal to have a randomized controlled trial, including medical therapy versus endoscopic sinus surgery, there are significant barriers, not least of which is the sham surgery, which is both unethical and difficult to recruit patients. As a result, surgeons must work with quality of life instruments. A patient's health status is determined by a patient's physical impairment, their functional limitations, and their disabilities and social limitations. The health status can be described both by the patient and the physician. Quality of life is a much more personal thing and can really only be described by the individual. The ideal quality of life instrument reflects important aspects of the disease, is responsive to the effects of treatment, and accurately reflects the impact of the disease on the patient's quality of life. Disease-specific instruments ask the patients about the impairments most important to them and focuses on specific problems, making them more sensitive to detect clinically important changes. There exist many different quality of life instruments for sinusitis, and a systematic review from 2012 reviewed how often each of those were used. The CSS, or Chronic Sinusitis Survey, was used about 31% of the time. The SNOT-20, or Sinonasal Outcome Test, with 20 questions, was used about a quarter of the time. The Rhinosinusitis Disability Index was also used about a quarter of the time. And the Sinonasal Outcome Test with 22 questions, or the SNOT-22, was used only about 7% of the time. Interestingly, many of these studies used more than one instrument. Of note, the SNOT-22 was not fully validated until 2009. And I would be willing to bet that if this study were repeated today, the SNOT-22 would have a much higher usage rate. Some important definitions for specific instruments include the validity. And the validity is defined as the degree to which an instrument measures what it's supposed to measure. Reliability is the way in which individual instrument items relate to each other. Responsiveness is the instrument's sensitivity to change over time. and the minimally clinical important difference, or MCID, and this is an important one, we'll use the MCID throughout this talk, is the minimum change that represents a relevant, perceptible, or meaningful change to the patient. There are several other outcome measures, and many of them have overlapped with each other. There's lost productivity, which is commonly defined as absenteeism plus presenteeism. Absenteeism is the number of days missed from work or school. Presenteeism is the percent of reduced daily work performance due to chronic rhinosinusitis. The monetized productivity loss is essentially the annual wage times productivity time lost. And health utility is fairly unique, and we'll talk about that a little bit more. If you have any questions or are interested in more details about these measures, I encourage you to look at the articles in the literature cited slide. Health utility is interesting for several reasons. A patient's utility measures a person's preference for being in their current health state. A score of 1 is perfect health. A score of 0 is death. A cost effectiveness analysis measures the costs and consequences of alternative interventions using clinical outcomes such as symptom-free days, complications avoided, or cases diagnosed. When a cost effectiveness analysis uses utility level as the outcome, it's referred to as a cost utility analysis. These are valuable because they allow outcomes to be compared across different disease states. That allows for shifting of healthcare resources between interventions, taking money from interventions that aren't as beneficial and putting it towards interventions that are more beneficial. So what is the evidence for endoscopic sinus surgery? We're going to do a deep dive into that. And we're going to start with the highest level of evidence, which is Cochrane database systematic reviews. There have been 2 looking at sinusitis and endoscopic sinus surgery. The first was from 2006. It included 3 randomized controls and a total of 212 patients. The first study looked at middle meatal antrostomy versus inferior meatal antrostomy, and they identified no difference in symptom scores. The second study looked at endoscopic sinus surgery, irrigation, and an antibiotic versus irrigation and an antibiotic alone. They reported significant reduction in purulent drainage and hyposmia in the endoscopic sinus surgery group. However, there is no difference in cure rate at 1 year. The third randomized controlled trial compared endoscopic sinus surgery and medicines versus medicines only. And they identified no difference in symptom scores after 12 months, including symptom scores such as the visual analog scale, the SNOT 20, and the short form 36. This Cochrane review concluded endoscopic sinus surgery does not confer additional benefit to medical therapy. However, they only included 3 randomized controlled trials, and the first 2 did not compare common medical regimens. Therefore, they really were inappropriate comparison groups. The third study also did not account for failed medical therapy, and patients have to fail medical therapy before they should qualify for a surgery. The second Cochrane review was done by Joanne Rimmer and colleagues, and this included 4 randomized controlled trials involving 231 patients with chronic rhinosinusitis with nasal polyposis. One study compared endoscopic sinus surgery versus systemic steroids. 2 of the studies compared polypectomy versus systemic steroids. And the 4th compared endoscopic sinus surgery plus topical steroids versus antibiotics plus high-dose topical steroids. They found no differences between the groups. However, the authors felt this was low or very low quality evidence and had low confidence in the estimates of the study. So the Cochrane review only included randomized controlled trials, which is great, since randomized controlled trials are some of the highest level of evidence. This again limits the number of studies included. They also didn't account for failed medical management, and these studies had inconsistency in medical therapies and really didn't use the maximum or the appropriate medical therapy that we use today. In 2010, the ARS developed a multi-institutional prospective outcome study that looked at 180 patients that failed initial medical therapy. Those patients self-selected continued medical therapy or endoscopic sinus surgery plus medical therapy. In the results, both groups reported significant improvements between baseline and 6-month quality of life scores. A crude comparison found the surgery cohort had more improvement in quality of life scores compared to the medical cohort. After performing regression modeling, controlling for enrollment site, age, asthma diagnosis, prior endoscopic sinus surgery, and baseline quality of life, the surgery cohort were more likely to have clinically meaningful improvements in the patient-reported outcomes. And the surgical cohort had significant reduction in exposure to antibiotics and steroids, as well as fewer days missed post-op. The same group reported on 1-year outcomes of these patients. They followed 115 patients for 1 year, and interestingly, 17 of those patients that were initially in the medical cohort crossed over to surgery, creating a third or crossover cohort. The authors reported significant improvements in mean quality of life scores for all 3 cohorts. The crossover cohort had initial worsening prior to crossover, presumably why they crossed over, then had improvements 3 months after surgery. Both the surgery and the crossover cohorts had greater improvements in the rhinosinusitis disability index compared to the medical cohort, and the surgical cohort had greater improvements in the chronic sinusitis survey compared to either the medical or the crossover cohorts. A different study by Luke Rudnick reported on 83 patients who underwent endoscopic sinus surgery for refractory chronic rhinosinusitis. At 1.5 years, these patients reported significant improvement in utility scores, and those scores were durable up to 5 years out. Of note, greater than 50% of patients reported utility scores greater than 0.81. This number is significant because 0.81 is the utility population norm in the United States. So if you look at everyone in the United States, the normal value for the utility score is 0.81. Another study by Rudnick and colleagues looked at productivity costs before and after endoscopic sinus surgery. They followed 27 patients with refractory chronic rhinosinusitis who underwent endoscopic sinus surgery. Those patients reported daily work productivity levels, their daily work productivity levels significantly rose from 81% pre-op to 92% post-op. These patients also had productivity losses, which showed a significant decrease from 63 days per year pre-op to only 22 days per year post-op. Again, a significant difference. The same study showed that patients spent significantly less time caring for their sinusitis, decreased from 26 minutes per day pre-op to 14 minutes per day post-op. And the annual mean savings to society was almost $6,000 per patient. Dan Beswick and colleagues looked at productivity costs by evaluating 202 patients that had refractory chronic rhinosinusitis who chose either medical therapy or endoscopic sinus surgery. The endoscopic sinus surgery cohort had significantly increased mean daily work performance from 84 to 92%, and significant mean monetized productivity losses of about $5,000 per patient. While the medical therapy cohort had no significant changes in either the mean daily work performance or the mean monetized productivity loss. They reported the greatest productivity changes were seen in patients who underwent endoscopic sinus surgery and experienced the largest improvement in the SNOT-22 scores. Another study by Beswick and colleagues looked at socioeconomic factors in 392 patients with refractory chronic rhinosinusitis. Their preliminary linear regression found that age, education, gender, income class, and health insurance provider were significantly associated with pre-op sinus symptom severity. Race and ethnicity were not associated with pre-op sinus symptom severity. After adjusting for enrollment location, revision surgery, asthma diagnosis, aspirin sensitivity, allergy, depression, and tobacco, their pre-op data showed higher age and male gender were significantly associated with lower mean pre-op SNOT-22 scores. Post-op data showed that after adjustment for enrollment location and revision endoscopic sinus surgery, lower age and upper income class were significantly associated with likelihood of improving at least one MCID on the SNOT-22. The same group looked at 242 patients and how socioeconomic status impacts productivity and health utility after endoscopic sinus surgery. They found that patients with Medicare and those in the lowest income tier did not report significant improvements in productivity loss, whereas patients in high income tiers and those with private insurance did in fact report significant improvements in productivity loss. Additionally, the Medicare group did not report post-op improvement in absenteeism days, presenteeism days, or lost leisure time, while the private insurance group did report significant improvements in absenteeism, presenteeism, and lost leisure time. After adjustment for multiple comparisons, the only significant difference in productivity improvements was between private insurance and Medicare. Finally, all study participants had significant within-subject improvement in health utility scores. 60% reported greater than or equal to 1 MCID post-op in utility scores, and the percent equaling the US norm significantly rose from 24% pre-op to 42% post-op. There was no statistical significant difference in utilities scores identified between any independent measure of socioeconomic status. A meta-analysis of SNOT-22 scores after endoscopic sinus surgery was done by Zach Soler and colleagues, and they found 40 studies of over 5,500 patients. All showed significant improvement post-op with a mean change of 24.4 points. There was no impact for age, sex, endoscopic score, CT score, polyp status, tobacco use, depression, or allergic rhinitis. Asthma, prior endoscopic sinus surgery, and higher pre-op SNOT-22 scores were all associated with greater degrees of improvement. And interestingly, studies with longer follow-up had smaller change in SNOT-22 scores. Another meta-analysis by Zara Patel and colleagues looked at various outcomes of endoscopic sinus surgery. For disease-specific quality of life scores, they found the endoscopic sinus surgery treatment effect was significant. For endoscopic grading, there was significant improvements in the endoscopic sinus surgery versus medicine groups. Interestingly, there was no difference in missed work days between the groups. And the biggest limitation was the significant heterogeneity in all the data sets. They also reported both statistical and clinical health utility improvements in surgery, but not in medicine. And they reported that 2 Markov decision tree models showed with greater than or equal to 74% effectiveness that endoscopic sinus surgery is the most cost-effective option for chronic rhinosinusitis. Moving on to long-term data, a retrospective study from the United Kingdom queried the National Comparative Audit of Surgery for Nasal Polyposis and Chronic Rhinosinusitis and found 1,459 patients with 5-year follow-up data. They reported that the mean SNOT-22 scores at 5 years were similar to the scores at 3 months, 12 months, and 36 months, and that all patients had at least one MCID improvement over baseline. A study by Tim Smith looked at 59 patients followed prospectively for almost 11 years, and they reported significant improvements in quality of life at 6 months post-op, and that improvement was durable for that almost 11 years. They reported that health utility values approached normal for the US population, and patients with polyps had significantly less improvement in patient-reported outcome measures during those 10.9 years. So what about the extent of surgery? Well, Adam DeConde reported on 311 patients and compared complete endoscopic sinus surgery versus targeted endoscopic sinus surgery. Complete surgery was defined as bilateral maxillary antrostomies, total ethmoidectomies, sphenoidotomies, and frontal sinusotomies. Targeted was anything short of complete. They found that both groups had significant improvements in the SNOT-22 scores. However, the complete surgery group had greater improvements in SNOT-22, but that difference was not significant. There was also no paradigm to identify subjects that would benefit from a complete surgery. Of note, the complete surgery group had worse disease as measured by CT scan, endoscopy, and SNOT-22, and the authors concluded that more study on the subject is needed. A combined prospective and retrospective study looking at 33 patients undergoing frontal surgery, with about half of them having balloon dilation of the frontals, showed that frontal sinus surgery alone or in addition to other sinus surgeries improves the quality of life of patients with frontal sinus symptoms. A study evaluating 226 patients undergoing endoscopic sinus surgery with or without frontal sinusotomy looked specifically at patients with less severe disease, specifically primary endoscopic sinus surgery, no aspirin sensitivity, no polyps, and no asthma, and they found that those two groups, those undergoing frontal sinusotomy and those not undergoing frontal sinusotomy, achieved similar quality of life improvements. So the authors concluded that ethmoidectomy is a potential alternative to frontal sinusotomy in patients with less severe disease. The group from the UK reported 5-year retrospective data from their National Comparative Audit of Surgery for Nasal Polyposis and Chronic Rhinosinusitis and compared simple polypectomy versus polypectomy with one or more sinuses opened. Their unadjusted data showed that SNOT-22 scores were significantly better for simple polypectomy. After adjustments for pre-op scores, that difference decreased, but was still significant. However, after controlling for age, sex, prior endoscopic sinus surgery, asthma, aspirin sensitivity, polyp grade, and unilateral polyps, that difference was no longer significant. If we focus in on frontal sinus surgery alone, most of the outcomes look at sinus patency post-op less than they do patient-reported outcome measures. A review by Adam DeConde and Tim Smith on frontal sinus surgery found that patients who underwent draft 2A frontal sinusotomy, majority of them experienced symptomatic improvement. The endoscopic patency rate was in the mid 80%. However, the studies were limited in that they lacked both baseline patient characteristics as well as validated disease-specific measures. A study out of Australia looked at 109 patients that underwent draft 2A, and they found that the patency rate was 92%, the revision surgery rate was less than 9%, and the resolution of symptoms was almost 80%. They found no correlation between eosinophilic mucin, asthma, polyposis, or smoking, and they found that the intraoperative diameter of 4.8 millimeters was critical for long-term patency of the frontal sinus. A systematic review of 26 articles looking at draft 2B for chronic frontal rhinosinusitis found a patency rate of 87.85%, and that rate went up to 93.5% when flaps or grafts were used. However, that added value was not statistically significant. They also concluded that the safety of a draft 2B was comparable to a draft 3. Another study from PJ Wormold's group out of Australia looked at their series of 229 draft 3 patients over a 10-year period. About half of those patients had polyps, and all of the patients had improvements in post-op symptom scores. They had a 97% patency rate after 3 years, 12 required revision, and of those 12, allergic fungal rhinosinusitis and colonization with Staph aureus were both risk factors for revision. However, only AFS was proved to be a significant risk factor. So does the timing of sinus surgery matter? Well, if you remember Tim Smith's prospective study from 2011, 34% of the medical management arm worsened and crossed over to surgery, creating that third crossover cohort we discussed. At 12 months, the crossover cohort failed to achieve the same level of symptomatic improvement as the initial surgery group. That begged the question, does delaying surgery impact outcome? To investigate this, Claire Hopkins and her colleagues in London did a retrospective review of almost 1,500 patients comparing outcomes based on the symptom duration pre-op. So they divided patients based on their symptoms into cohorts of symptoms duration of less than 12 months, symptom duration of 12 to 60 months, and symptom duration greater than 60 months. And they found significant improvement in SNOT-22 in all 3 groups. However, greater improvement for the early versus the late cohorts. At 60 months, the percent of patients with an MCID was 71.5% for the early cohort, 57.3% for the mid cohort, and 53% for the late cohort. This data suggests that operating on patients sooner rather than later portends better outcomes. A follow-up study by Jeremiah Alt and colleagues was a prospective analysis of the relationship between symptom duration and outcomes. They followed 78 patients and used the same pre-op symptom duration cohorts as described. They followed these patients for almost 15 months after endoscopic sinus surgery and found that all cohorts had significant improvements. And interestingly, the long-term cohort had significantly better SNOT-22 scores than the mid or the short-term symptom cohorts. So in conclusion, outcome studies are needed for surgical interventions. There's strong evidence supporting the benefit of endoscopic sinus surgery on quality of life and utility. The extent of surgery performed may impact the benefit of endoscopic sinus surgery, and there's conflicting data on the timing of endoscopic sinus surgery. Key points include surgically based studies do not ethically allow for a control group, which limits their usefulness. CT and endoscopic scores don't accurately measure patient-reported disease severity. SNOT-22 scores accurately discriminate between patients electing endoscopic sinus surgery versus medical therapy. And endoscopic sinus surgery provides significant, meaningful and durable improvement in health-related quality of life and patient utility levels. I encourage you to read Zara Patel's meta-analysis published in IFAR in 2017, the most recent International Consensus Statement on Rhinology and Allergy in IFAR published in 2020, Joanne Rimmer's Cochrane database review for chronic rhinosinusitis with nasal polyps from 2014, and Tim Smith's long-term outcomes of endoscopic sinus surgery published in the International Forum of Allergy and Rhinology in 2019. Here are the references. I hope this was valuable. Thanks very much.